Hi, my name is Nina Litvak. I'm from Springfield, Illinois. I went to Springfield High School. I currently attend the University of Illinois at Urbana-Champaign, where I major in community health. I want to pursue a career in medicine, specializing in obstetrics and gynecology, and my mentor is Dr. Braunmeyer Fleming. The project I've been working on this summer is the evaluation of immune mediators in gynecological cancers. The first thing I want to talk about is why we are studying these gynecological cancers, why this is important. Endometrial and ovarian cancer are two of the most common types of cancers of the female reproductive tract. The exact cause for either of these cancers are unknown, and they're often diagnosed at advanced stages, which leads to high mortality rates. It was estimated in 2020 that 14,000 women would die from ovarian cancer and 13,000 women would die from endometrial cancer. One of the reasons they are diagnosed at advanced stages is because the symptoms are vague, things like abdominal pain, bloating, and distension. These are all pretty general symptoms and could mean any number of things. We also need earlier detection for these cancers. I'm going to be focusing on what impact the presence of ovarian and endometrial cancer has on a patient's immune system. It has been highly published that endometrial and ovarian cancer drive inflammation. I want to discuss what this inflammation looks like in the immune system. When the immune system is balanced or in homeostasis, there are even amounts of two different types of immune cells, Th17 and T regulatory cells. Th17 cells are attacker cells. They are like a general that recruit other troops or immune cells to attack foreign invaders. And this could be something like cancer. So when there are high levels of Th17 cells, there is inflammation. On the other side of that scale, there are T regulatory cells, and T regulatory cells are tolerant and suppressive cells. They tell Th17 cells to calm down, that they do not need to attack so much. So when there are high levels of T regulatory cells, there is insufficient disease clearance. For example, a tumor continuing to grow. Our first piece of preliminary data was to look at the immune profiles in women with gynecological cancer. We wanted to look at the Th17 to T regulatory ratio to see if there was an imbalance. We took the blood of patients with endometrial cancer on the day of surgery and throughout their postoperative care and looked at their immune cells. We saw that Th17 cells were very high and T regulatory cells were outnumbered. This tells us that patients with gynecological cancer are highly inflamed. Now that we know that patients with gynecological cancer are inflamed, we wanted to see how these immune cells were driving this inflammatory environment. So we looked at immune mediators. The immune mediators we looked at were cytokines, because that is what immune cells produce in order to drive an inflammatory event. We compared patients with endometrial and ovarian cancer to their controls. And the controls for endometrial cancer were healthy women, and the controls for ovarian cancer were women with benign adnexal masses or benign tumors. And I would also just like to point out that the scales in concentration are different for endometrial and ovarian cancer. For endometrial cancer, it's from 0 to 350, and for ovarian cancer, it's from 0 to 1,000. We found that there were significantly elevated inflammatory cytokines in patients with ovarian and endometrial cancer. This tells us that not only are patients with gynecological cancer producing inflammatory immune cells and inflammatory mediators, but that they were taking on this inflammatory profile or inflammatory phenotype. The next thing we wanted to know was what could be driving this inflammation other than the cancer. One of the things we study in Dr. Braunmeyer's lab is how the microbiome interacts with immune cells. The microbiome is the makeup of microorganisms that live on and in our body. This can include things like fungi and protozoan, but mainly today we'll be focusing on bacteria. From this image, you can see that commensal bacteria produces things like short-chain fatty acids, flagellin, LPS, and sphingolipids. All of the red arrows indicate how bacteria can regulate epithelial cells and thus immune cells within the mucosal surface. Additionally, you can see that the blue arrows show how the immune cells regulate the epithelial cells and thus microbiota. So these two systems are able to interact. Microbiota can also drive inflammation, and this is a really important thing to study in patients with gynecological cancer. So we know that patients with gynecological cancer are inflamed and that microbiota can drive inflammation. The next thing we wanted to find out was if patients with gynecological cancer had an altered microbial profile, and the answer is yes, they do. So we compared control patients, healthy women, to stage 1 and stage 3 endometrial cancer, and we found that lactobacillus, which is an anti-inflammatory bacteria, greatly decreases as endometrial cancer progresses. And this would make sense because patients with endometrial cancer are inflamed and they are losing a bacteria that reduces inflammation. We also saw a microorganism that was increasing. These two things tell us that patients with endometrial and ovarian cancer have an altered microbial profile. So our hypothesis is that cancer causes inflammation, which then alters microbial profiles, thus further driving inflammation. We've seen that cancer causes inflammation with those high Th17 cells, and we also saw that the immune mediators, those inflammatory cytokines, further drive inflammation. We know that there's an altered microbial profile in patients with gynecological cancer, and that these microbiota can produce immune mediators that also further drive inflammation. What we want to find out is how the immune cells and microbes communicate with each other through these immune mediators, if there is any communication at all. To test this hypothesis, we developed the following study design. At preoperative appointments, we would approach patients for enrollment and obtain their informed consent. On the day of surgery, there would be tissue collection from patient's primary tumor, and then we would cryosection those tissues and place them on microscope slides. This is similar to what a pathologist does when they are testing to see if a mass is benign or malignant. But what we're going to use these microscope slides for is MALDI and mass spectrometry to identify who, so what is present, and the localization where these immune mediators are in control and malignant tissues. There are two different types of mass spectrometry. There's liquid and gas chromatography. Liquid chromatography is used to quantify bigger analytes, and gas chromatography is used to quantify smaller analytes. Analytes are just proteins, so mass spectrometry uses electron beams to determine the size of these proteins or these analytes in order to tell us what is present and how much of these analytes are present. MALDI is also able to quantify analytes, but it can use a laser to determine the spatial distribution in tissues. This means that we can see where these immune mediators are located in control and malignant tissues. The immune mediators we have identified are on this table here. Arachidonic acid, arachidinate, and prostaglandin E2 are all inflammatory mediators. Propionate, succinate, butyrate, and acetate are antimicrobial peptides. Antimicrobial peptides are responsible for regulating and controlling microbial diversity. Vitamin C and uric acid are antioxidants, and these antioxidants can reduce inflammation. All of these mediators have an association between the microbiome and immune cells, so the microbiome is able to produce these metabolites, and so are immune cells. The images here are MALDI imaging from endometrial cancer tissue. On the image to the left, the black that I'm circling is the endometrial cancer tissue. And the image to the right shows the metabolites that have a mass to charge ratio or a size of 370 Daltons. So everything that is colorful show the expression of the metabolites of this size that are present in the endometrial cancer tissue. Red shows areas of high expression, pink shows areas of moderate expression, and blue shows areas of low expression of this metabolite. We believe that these are possible high levels of expression of prostaglandin E2, and this would make sense because these two metabolites are similar in size, but this has not yet been confirmed. If this were prostaglandin E2, again, this would make sense because patients with endometrial cancer are inflamed, and this is an inflammatory mediator. From the study, we can conclude that cancer causes inflammation, which then alters microbial profiles, and both the immune cells and microbiome are able to produce metabolites that further drive inflammation. I also want to discuss how this impacts the patients. We are hoping to identify the unique inflammatory status in patients with gynecological cancer and target the metabolites that are further driving this inflammation. By targeting these metabolites, we are hoping to reduce inflammation, and that will allow the immune system to return to homeostasis or return to being balanced so that it can control metastasis and cancer growth. I would like to say thank you to my mentor, Dr. Braunmeyer Fleming, our clinical collaborator, Dr. Berard, Simmons Cancer Institute, Han Do, Teresa Wilson, Dr. Diaz Sylvester, Kathy Grosh, Dr. Tucker, and Stephanie Shan for making all of this possible.